First of all, I think if you wouldn't mind introducing yourself, Cully, because we've heard from everyone else already, and it'd be lovely so that people know in the room who you are.
So I'm the service manager for Birmingham Healthy Minds, which is the IAPT service in the Midlands, one of them. You know, my kind of real sort of passion is about staff wellbeing and really wanting to develop digital services within IAPT. And we've kind of made some strides, but listening to this morning, we've got a long way to go. So I'm really excited about the opportunities in the future. So, yeah.
Brilliant. It'd be really nice to start with you, Cully, because so you mentioned to me earlier this idea that you've got digital ambassadors or champions. Could you tell us just a little bit about them and how you're trying to use them to sort of bridge this divide and overcome staff wellbeing issues?
So essentially, probably like a lot of IAPT services, computerised CBT was one of the sort of the first kind of ways of delivering interventions outside of just kind of like one-to-one, face-to-face intervention. So that's where we kind of really started. We were one of probably the earlier sites to have developed that. We've been with many providers, have got lots of experience of, you know, working and developing that. And on the back of that, we've sort of really tried to embrace, you know, different ways of working, innovative ways of working, trying to sort of cut costs, trying to do work smarter, not harder, and really sort of working through, you know, using the information that we've got without duplicating stuff. So really trying to go through a paperless service, really trying to sort of work on different ways that we can, you know, work together with, you know, saving time and saving energy, really, you know.
Interesting. So that's looking at it from the kind of the staff point of view. One of the questions that's come up in Slido which is to all of you really, we've talked a lot today about digital, the whole day is about digital, and someone's asked the question, is this what patients actually want, and how do we know? I don't know if one of you wants to kind of come back on that, maybe.
Yeah. Oh, you can hear me.
We can hear you.
Magic. For us, in terms of the development of our VR work in Grenfell, we've very much engaged with the local community, and it's really important to do that. So, for example, when Grenfell first happened, the survivors and the bereaved formed a group called Grenfell United, and we were really keen that when we started to look at the development of VR, that we cited our first kind of a stable VR port at that point, and they had a dedicated VR room. So the survivors and the bereaved, then when we went to work with them, it was very much an iterative process. It was, do you like this? Is this interesting? Is this helpful? And very much having their voice through everything that's developed. So from that perspective, as you look to develop services, having the groups that are affected most by, you know, what you intend to support people with, having them from the ground up is really important.
How about you, David? Have you got any thoughts on that? Do we know this is definitely what our patients, what our clients actually want, that they're embracing the digital future?
Well, they're not. So, I mean, there's a very large literature on internet-based therapies. There are over 230 randomized controlled trials in depression and anxiety. Very few studies of patient experience, and that's a big gap in the literature. And I think, you know, if these things are to be made more widely available in IAPT, we need to listen much more to the patient voice and be much more attentive to that. And firstly, you know, it can only ever be a choice item, so it shouldn't be the only thing you're going to get is this digital therapy. People must have a choice between that and more conventional therapy. But then I think one needs to look very closely at what people's experience is as they go through it and learn from that. And I think one of the issues we have in IAPT is training people to deliver these digital interventions in a way which makes the most of them and makes patients enjoy them most. And you do need to work differently with them. So a lot of IAPT services, you know, people have very full diaries and they have patients scheduled, you know, this hour, and this hour. And it's more organized around seeing someone once a week or calling them once a week. A lot of these digital therapies aren't designed that way. They're designed for much more frequent communication, where you might actually send someone an SMS message or an email or something like that many times a week. There's some like Silver Cloud, which is more, I think, once a week, phone call, but others like OCDNet, for example, where it really is much more this continuous interaction. And we've done some studies where we've looked at what patients' perception is of the support they get on a digital program versus in a sort of face-to-face. And in those ones which allow this very frequent but very brief communication, what we find is that the ratings of the therapeutic alliance are extremely high as in face-to-face therapy. But when you interview patients about it, and this is surprising because they're not seeing someone face-to-face, and therapists' ratings of therapeutic alliance are more positive if they see someone face-to-face than if they're treating them on the internet. So therapists think the relationship isn't so good, but at least in our trials, patients disagree with them. They think the relationship is good, but it is with this particular frequent form of communication. And when we've asked people, well, you know, why are you rating it that highly? They said, well, if I was having face-to-face therapy, if I've understood you correctly, I'd come along once a week and I might have an hour with someone and then I'm on my own for the rest of the time. But with this digital therapy, I feel that my therapist is there all the time because I'll do a task and I'll get a message saying they're going to be looking at it that afternoon. And it's like a text conversation with my friends who are in a different city. We're texting backwards and forwards all the time, and it's like one continuous conversation. Yeah. But that is a very different way of interacting to the way we normally set up therapy. Yeah. And so if you want to establish that close relationship with people, you need to adjust the way you interact with these digital things.
Have you got thoughts on that, James? How does the relationship look different when we're embracing these different kinds of therapies? And how do we need to think really carefully about how do we safeguard ourselves in that relationship? Because when we're constantly accessible in that way, there must be some ramifications for that too.
So I think a reflection from my own clinical practice. So we've set up in my clinical team, working with children and young people, a online health record that allows young families, parents to instant message us and kind of, about medication queries, about behaviour at school or so forth. And I think one interesting thing that we've reflected upon is that some of the parents will finish their messages with XXX because they're so used to messaging in that way. And I guess you've just got to kind of adjust that. And I guess, we've had a conversation in my team about emojis, do we, because actually there's a language when it comes to that kind of thing. So I think it's about being cautiously playful and having that almost talking out loud about it with patients as well, or with the families we work with, and saying, how does that feel, and getting that feedback and kind of going on that journey together. I think if you try and force it into a more formal kind of, trying to kind of almost write like a management memo over this instant message, you just don't get the response. If you engage them at the right level, actually, it's very powerful. So I think that's that calibration. It can be tricky, and some of my team have found that harder than others.
But that's when it's working well, isn't it? And that's when people are engaged and they've kind of overcome maybe that initial fear. But I wondered, Cully, if you were happy to talk a little bit about how do we get people to take the plunge? Because this can feel quite scary, can't it? Engaging in this different way. It's different than face-to-face.
Yeah, and I think for us, certainly one of the things that we found was actually it's a great culture shift in the way staff work. And actually, one of the best examples I can give you, when we first set up the service and trying to meet that demanding capacity, we were trying to work more towards telephone interventions. And the most people that had the problem about that was the staff, because it was like, just like David was saying, no, this isn't going to work, and I'm going to miss verbal cues and all of that. So I'm sure a lot of the audience know that actually, it was really about sort of starting small and sort of, piloting it, getting that feedback from patients saying, actually, this was really good. I didn't have to spend, £10 on a taxi to come and see you. I could kind of fit that in a time scale that suited me. And also I was, sometimes actually the face-to-face speaking to somebody not face-to-face was actually a really good way of disclosing things that they may not have done, in a one-to-one really. So actually it was that sort of learning, small steps, and then sort of trying to convince the whole wider service that actually this is a really good way to go. So
you use those champions again.
That champion sort of, and getting staff on board first really, and some patients on board as well, because the other thing, the other example I can give is about group work. This gold standard, everything has to be one-to-one, in that lovely room with lovely pictures and plants. Actually, it doesn't really happen in the real world. some of the surgeries we work in, they're like broom cupboards, so you just have to kind of make do with it. So, you know, yeah, so...
How about you, Ross? So when you talked about your work with VR, it sounded very much like absolutely everybody wanted to come and try this on and give it a go. Did you ever have people who were kind of more reluctant, and how do you encourage people to kind of engage with this tech they might not have used before?
Obviously, there are people that are reluctant. There's also an element of humanity that suffers from kind of a motion sickness in VR. Okay. So one of the things that we say to people before we offer a VR headset is, you know, you might feel unwell. This might not be the right thing for you. We encourage people to take the headset off if they do. Also, I think, you know, it is quite a different technology, and it's a shift to something new. And I think people feel like, well, I'd like to have some therapy rather than just mess around with VR. But I think for us, it's, you know, it's increasing the opportunity to reach out to different people in the community that might not have come before. So for us, it's that openness and availability for everyone. I just also wanted to touch on myself and James are working on a project across London where we're looking to create a single point of access for all London IAPT services digitally, so to have a digital platform. And one of the things that we've recognised through that piece of work is that there are varying levels of digital maturity across services, but also within services. And I think it's really, really important that any shift towards digital products or digital enablement of the clinicians need to have a supporting kind of change management process around it. So it needs to be underpinned by a level of education for the clinicians using the tech, so they are ready and they will champion it themselves. You know, as I said in my talk, it was really, really important for us to give the tech to the clinicians before, so they got used to it, they felt comfortable with it, they could decide themselves if they liked it or not, and that helped them in the end to kind of move that way.
So playing devil's advocate there then, we sometimes think that, you know, the use of tech, this is going to save us kind of time and ultimately money. That sounds slow and expensive.
That is true, and I think we need to be upfront. I think when we've had new technologies that have come into IAPT previously, they've been kind of sold as this will save you time, this will make you as a service more effective. And I think for the first 3 or 6 months it doesn't. I think it's only at a point where people get very used to the technology that then you start to see the time saving and the impact that it can have. But I think up front it's useful to actually say this isn't going to speed up your work initially when you get used to it.
How about from your point of view, David, when we're looking at that from the kind of national picture and we're thinking in terms of kind of, you know, our outcome measures and what we're seeing with regards to patients, I mean, how does this all sort of fit? So we're sort of maybe understanding a little bit about how we overcome those initial hurdles and what might be the benefits and the difficulties there. But what for you is the kind of, what are the questions we need to be asking here? What are our kind of key concerns?
Well, I think the first thing is that we don't drop the quality of the therapy. So if you're talking about IAPT, then any of the interventions that we have to be delivering the nice recommended content, and they also have to be safe. But then, just like, you know, with delivering brief psychodynamic therapy or IPT or CBT, we have to train the workforce to be able to deliver them competently. And that's the same with these digital things. I think Ross has made a very good point. You can't just take one of these programs and start using it with your patients. Mm-hmm. You need to know it inside out, and you need to have quite a bit of supervision to get really good results with them. But of course, once you've done that, then it can work very well. So the question is, how can we make this happen in IAPT, especially as this is a new field and we don't really know the best ways of supporting people across different digital things. So we can't change the curriculum at the moment to give everyone a core in how to support someone with an online therapy, although we will eventually. So we need to build into the system ways of learning, and there is a quite big change that's about to happen. I think maybe in 3 or 4 days' time, where what we've done is we've asked NHS Digital to start producing outcome data for each CCG, where you don't just get the outcome from the beginning and end of therapy in IAPT, which is often more than one thing. It might be low intensity and high intensity, but rather we track symptom change and disability change from the first session of an intervention. It might be an online treatment to the last session of that intervention, even though someone might carry on afterwards. So then you will be able to see, how well are people doing just with this intervention in my service. And that's about to be published for depression by NHS Digital next week, I think. So you can look at how all your existing therapies give different amounts of change, which I think will help people think about how they're deploying their therapies. But critically, what we've decided for the minimum data set version 2 is we'll have an open field where you can select new digital programs that you're bringing in, and it will expand as extra programs come in. So each service will be able to see what are the outcomes we're achieving just with this program, with these different patients. And of course, you will also be able to see what are the outcomes that the service down the road are achieving with just that program. And you'll find they're different. And so you'll find it isn't just the program that's important, it's the way you deploy it. And then hopefully people will have conversations and networks and learn from it. Using, it's the same principle that we've used throughout IAPT, but we want to apply it now to the digital interventions as well.
And do you think using these sort of digital interventions and changing a little bit about how we're kind of measuring and sharing outcomes might enable us to kind of close this gap a bit in between kind of research and practice? Because Andre, anyone who is following on Twitter will have seen Andre in the corner here tweeting away from Mental Health about today. And we had a great conversation earlier about how we're trying to close that gap. It's 17 years, was that right, Andre, you think, between research actually becoming practice? I mean, this surely has the potential to help us work much more live and respond much more quickly.
Yeah, so that's the point. It is exactly in order to close that gap. The gap is getting shorter, though there was a sort of study in 1624 where the British Navy gave a sort of barrel of lemon juice on one ship that was going down to India and not on 3 others, and only 75% of the sailors who were on the ships without lemon juice were dead by the time they got to India, but only 20% of the ones that got the lemon juice, and it took the British Navy 200 years to implement the results of that. Well, we are getting faster, but we need to get a lot faster, and the sort of evolution of the data set in IAPT allows you to do that very quickly indeed. I should also mention actually that funding bodies are beginning to get smart like this. So Daniel Freeman's team, who work on VR, they've got, as far as I'm aware, the first ever grant from NIHR, which actually takes you from developing a product, a VR product, a multi-center randomized controlled trial, developing a spin-off company that will make it available in the NHS and getting it into the NHS, all in one grant. Yeah. You need a big team with different skills to do it. But that's the way we have to go, because I think one of the reasons why psychological therapies don't get as available as they should do is that you get all this basic research on whether they work, that's funded well by research councils, and then nothing is funded about implementation. The competitor is drugs. Well, of course, a drug company will never do that. They'll do the trial, and then they'll put in billions to make sure that drug is available in every GP practice. Yeah. And we have to work out how to do the equivalent, but without the billions.
Yeah. So the hope is that the tech evolves fast, we learn fast, all good. But Cully, are robots going to take all our jobs? We're all wondering, aren't we?
That's funny, because that is one of the fears, really, in terms of, for staff. That is a real kind of concern, And I did have somebody say, so does it mean that we're going to be going, getting your therapy like cash, when you get cash out the wall, So there is a little bit of concern about that, to be fair. And I think, in sort of, to add that, as a service manager, the real constraints around sort of, funding and actually investment, is still an issue, and we all know in this room that, the sort of recruitment and retention of staff, when I think you were saying earlier about getting the right skill mix, and I'd just be happy to have any staff at the minute. It'd be like, it's like, please come and join us, because we're so short. The workforce, as David said, really does need a lot of investment. We're losing a lot of people. As fast as we're training them, we're losing them, and that is a real issue.
Can I address this? I mean, there is absolutely no possibility that these things are going to take over the jobs of IAPT therapists. Absolutely no possibility. And in fact, all the digital things that we're looking at are essentially therapist-assisted interventions, because the IAPT workforce is a wonderful workforce, and we just want to help them to do more things. And so this isn't instead of or an alternative to. It's really empowering people. And we still have, totally scandalous undertreatment of anxiety and depression. I guess we haven't. The latest adult psychiatric morbidity survey was in 2014, so the position must be better now. But in the 2007, it was only 25% of people were getting any sort of treatment for mental health problems. In 2014, it was up to 33%. It's probably maybe 42% now with IAPT. It's still the minority.
Yeah.
I think we've also seen, in terms of the precursors to digital therapeutics, when they were standalone, the adherence to and the results from were nowhere near as good. Now with blended therapies, the recovery rate, the access, people actually completing a course of treatment is much better. But it's digital therapy options should always be something that augments therapeutic practice rather than taking over it.
You had a point.
So I was going to say, I think the robots are going to take over some jobs, but the jobs that are going to make it easier for us to stay focused in the room when we're with the people that we're helping, whether that's a virtual room or a kind of real room. And those are going to be jobs around diary scheduling, or driving your car for you to your next appointment, or managing your shopping for you. So actually you're freed up that mental headspace, and I'm sure many of you have had that experience of sitting in a room trying to help somebody, and actually you've got a little tick in your head going, oh, don't forget to pay your gas bill, or don't forget to do that. That's the kind of stuff where I think robots will take over and will actually make it easier for us to stay, like I say, in the room when it comes to providing and being with people and helping them.
And I can give you a good example of that in these digital programs. So often if you've got anxiety, you'll be encouraged to do some sort of rather challenging behavioural experiment away from the clinic. And obviously, in an ideal world, we'd quite like it if you could talk to your therapist just before you do it, and again just after. But we don't have the capacity for that. But you can schedule SMS messages which send someone a note saying, looking forward to hearing how the experiment goes. When you've scheduled it, they get that message on their phone, and then they know that you're going to be interested in it, but you won't log on till the next morning. And they know it's an SMS message, and they know it's an automated SMS message, but our experience is people still say they think they're supported by that. They know that someone's going to be interested in it in the next day or so, and that's wonderful. So that really empowers you. It's the same point, isn't it? Yeah.
Yeah. So in terms of kind of getting our workforce kind of ready and thinking about the kind of the skills and things that we need to develop, because you've talked about the sort of importance of training, what do you think are the kind of gaps at the moment? What do we need to do to enable our teams to move forward with some of this? Blank faces.
Well, so there is a nice and NHS England evaluation programme going on at the moment of some digital interventions. And in that programme, what we do is we make the interventions available in a small number of pilot services, and we ask the providers of the programme to do an intensive training programme and supervision with the local staff. And we think we're learning quite a lot from that about how to do it. And then, of course, the issue is to then make that available elsewhere. So I think, if we're looking at the providers of online therapies, we should be requiring them to provide very good training and show that the training really works, just like any other training in IAPT. It isn't just a matter of selling the product and then letting people get on with it. That's pretty useless.
I think there's another gap that we've identified through our London Digital IAPT programme, and that's PWPs come in, and when they're trained into their role, there is a digital therapy element to their training. That's not the same currently in the high intensity programme. So high intensity workers that have come in not via the PWP route won't have had that training. So I think what we're looking at in London is certainly working with HEE to develop a package to make sure that everybody has had a kind of a basic level of training that's overall. I think it's also important to match that training to the core competencies of the clinicians, so to make sure that actually what they need to do is linked in that digital training as well, and that's something that we're looking at through the London programme.
And how are you finding that in Birmingham? Does that kind of reflect your...
Yeah, it's really important that, you know, people are competent to deliver those interventions in the different modes, really. And everybody's different, to be fair. Some people really jump at that and absolutely love it, and other people don't. It's actually working with individuals and sort of having that choice element as well. You know, I mean, I've got some workers who are quite happy to do telephone triage all day long, you know, and others, you know, they much prefer the face-to-face. And so you kind of work with the clinicians and their strengths as well. And obviously inclusion in terms of their, you know, some people can't hear, you know, that's harder for them, and working with disability, working with, you know, different cultural styles and everything. So, you know, but again, I agree, you know, training, supervision is key to that, really.
I mean, the internet obviously opens up lots of possibilities for training, and particularly free training. Yeah. And I think we need to make more use of that. So, for example, our clinic has a website called oxcadatresources.com, if you want to look at it. And there we put free workshops from me and other members of the team. You can either pay £200 to go for it, or you can stream it free. And we have lots of short video clips of key techniques, including actually how you prepare for a phone call with someone who's you're supporting through a digital therapy. And that's all free, and there are people in 50 different countries who are now logging on and using this website. And we encourage other people to do the same, because, you know, the whole point of the internet is really to provide open access to all these things. We need to be less protective and make these widely available. Because modelling is in many ways the best way to learn. It's not just reading a manual about it, it's actually seeing someone do it.
Yeah.
I suppose I was just thinking, don't forget the plumbing, which is, I think, you know, that experience of waiting for 10 minutes to turn on your computer can have a profound impact on your bias about technology. So, it's working with staff around, you know, what bits of technology actually do they get on with? Don't just assume that everyone likes an iPad. It might be a laptop. People might prefer laptops. And I suppose it's kind of that user-centered design approach, which I think is absolutely critical to some of this. And I think we probably need more design thinking in the NHS in general than we have at the moment. I think that's one approach that I think could be quite fruitful in trying to get to the issues that might be important in your locality. But yeah, particularly around what the plumbing looks like before you get onto the interior decoration.
And I think just picking up on that, I mean, you know, when we're in a situation where for some colleagues it might take them 10 minutes just to get into their emails because they're working on, you know, machines that are kind of run by hamsters on a wheel or something somewhere. I mean, how ready really are we for some of this, you know, really exciting new tech?
So I think the NHS has set out you know, companies, well, the industry benchmark for investment in technology in companies is 4 to 5% of revenue, or 4 to 5% of, you know, kind of your investment. Probably most NHS trusts are down at 2%, 2.5%, maybe even less than that. So I guess there's a fundamental shift in actually we're going to have to invest more in this to get that plumbing right, to get that experience right in order to get those benefits. So I think that's a really tricky question, and I think if I talk to my colleagues, my fellow chief clinical information officers in different trusts and chief information officers, that's a really tough, how do we get that under the cost pressures that we've got everywhere else, and everybody must have the same in terms of trying to reduce their overheads, but at the same time being asked to spend 4 to 5%, it's a challenge.
Absolutely, yes.
Maybe I can make a sort of general comment about this thing of how ready we are as clinicians. So there was a really critical decision that was made when we started IAPT. We thought it was very revolutionary. We thought the idea that you would try and record outcomes on everyone that you treat, and that you would report that information, was an idea that many mental health professionals would not be happy with. The idea that you should focus your treatment on giving nice recommended treatment was also one that we thought many mental health professionals would not be happy with. So we didn't try and force people to do that. What we said is, IAPT will not be something that involves changing your existing services. It will be something new on top of existing services. There's so much under-treatment of mental health that there's space for extras. And so we didn't try and transform services from within, but we operated on a principle, opt into the revolution. If you want to work this way, if you're interested in working this way, there's a possibility of a new job in a new service that follows those principles. And that's really critical, because you shouldn't be forcing people to go in a particular way if that's not something that they think is the right way for them to go. And I think as we introduce digital things into IAPT services, we shouldn't be trying to force all therapists to also be digital therapists. It needs to be the same principle. You take those people who are really interested in doing that, and you help them and you give them training for it, but you don't sort of do this in a you've got to do it form. It just won't work.
Absolutely. I'm aware of time. It'd be good to have just a brief closing thought from each of you before we move on to the rest of the day.
I was just kind of thinking about a conference I went to recently, and you know how you have the Maslow's hierarchy of needs, and at that conference they added 2 more boxes, and one said Wi-Fi and battery life. So that was just really, I thought that sort of sums it up for me, you know, that is the way we're going, to be fair, you know, so.
I think for me, at a previous conference a few years ago, I sort of said that Columbus didn't invent a new way of sailing, he just sailed over the horizon. And I think there's something about making sure that we hold on to the core skills that we have as clinicians working in mental health care, and we don't lose sight of just how powerful they are, and we just need to sail over the horizon and hold our nerve. And I think that's probably, you know, where I'd leave it.
I don't think I need to add to that. I think that's correct.
For me, I think it's just about, if you're going to be successful in implementing something new, you need the clinicians' buy-in. So it's about creating that environment where the clinicians get excited about the potential for tech and how it can benefit them, and letting them sell it to the other clinicians themselves.
And my closing thought would be, not everybody likes pictures of dancing cats. So when I was struggling with anorexia, then my therapist got me engaged with a really widely used app, which I think is great if you're a 14-year-old girl, but as a 36-year-old woman, being greeted with cat memes each time I managed to get through a meal wasn't quite doing it for me. And on that note, we'll thank you ever so much to everyone on the panel.